range 70 to 110 according to the American Diabetes Association. And like we talked about, 60s where you might get some cognition, 50 could be coma. Unless, of course, everybody's different, nobody's a perfect patient. Lots of symptoms here that they're going to feel, but the little acronym that's out there is cool and clammy. You need some candy because that's the most often your patient will complain of chills or feeling cold. And then their skin will actually be diaphoretic. They'll feel damp. Has everybody ever felt an oyster? Or at least know what an oyster, that's exactly what their skin's gonna feel like. It is the weirdest thing. They will feel like you're feeling an oyster or a clam. They'll have that little seafood texture. It's really weird. Then how we're gonna treat that is the 15-15 rule, which 15 is our favorite number for diabetes. Orange is our favorite color for diabetes. So 15-15 rule, you will give them 15 grams of carbohydrates and check their blood sugar every 15 minutes until they return back to their baseline of 70. So several options there. Obviously, if they're cognizant, they can swallow, they're with you, answer questions semi-appropriately, we can give them something orally. If your patient is not conscious, you will be amazed at people that will try to poke the gel under their tongue and they are not conscious. They will choke and aspirate. Now we have aspiration pneumonia to worry about. So if they are not alert, please, please, please do not give them anything PO. And then you can give them juice or soda, if so calls for, sugar, honey. If you're at home, you're like a paramedic or emergency home health nurse. I don't have glucagon with me, but let's ramble in the pantry, see if we can find one of those. And then hard candies, jelly beans, gumdrops. So you will teach your diabetic patients to always have some sort of emergent sugar supply on them in their backpack, or with a school nurse. Somebody needs to have teachers that are not nursing background or have not had those students to have a sugar supply, some candies in their desk for said reason, and then we can check them. I think that's it there. Questions about hypoglycemia? Okay. Dawn phenomenon. Dawn phenomenon is where we don't adjust really to our, it's not a response to hypoglycemia. It's just where in the morning when that growth hormone's going, we skyrocket, and it does not discriminate between type 1 and type 2. It's in both. Typically your Somovi's in type 1, but we're going to be there. So obviously for Dawn phenomenon, we may have to increase their basal insulin or may increase the evening insulin. So obviously the oral meds, who would the oral meds be for? Type 2. So put parentheses there, don't fall for the type 1 right there because we're technically still in type 1 section. But that's oral meds for type 2. And then the best way is to program that insulin pump. So you can adjust those settings at nighttime to be a little more aggressive so that we don't spike in the early morning time, typically between 4 and 7 a.m. Then the opposite side of the coin, Somogy effect. It's where you have hypoglycemia during the night and then your body overcompensates and has rebound hyperglycemia. This is usually related to too much evening insulin, so we would back off their nighttime dosing so that they don't dip as low at sleep time. And then we would, obviously to treat it, reduce that PM insulin if that's happening chronically. If it happens once or twice, it could have been diet related, could have been stress related, could be that we were just getting over the infection, something like that. Don't adjust permanently based on that, just kind of treat it acutely and leave it alone. Then our other side of the worst case scenarios are diabetic ketoacidosis. This is where essentially your body is going to produce ketones. Essentially your body is not responding or producing enough insulin, so your sugar stores go high. When your sugar stores go high, it's going to start breaking down your body because, again, that glucose cannot get, that's what's so confusing about this. It's like, well, their sugar's 500, why do they need, because the glucose can't get in the cell because they're not producing insulin. So their body's going to start breaking itself down, muscle and bone, like we talked about earlier, and that puts your body in that acidotic state. And so due to the acidosis, then we start producing ketones in the urine. All the glucose that's in my urine's also like punching on the kidneys, for lack of a better word. And so it's kind of a systemic shutdown in severe cases. So your hallmark signs for ketoacidosis is going to be a hyperglycemia, typically greater than 500. Your book, I think, it says even up to 750, but don't, just greater than 500 is high. You have the presence of ketones in the urine, and if I were to do an ABG, you're in metabolic acidosis. And that would be your key takeaways. So, in treatment, obviously, what do you think you're going to do for it? Could. Insulin. Now, not this semester, but next semester, I'm going to go ahead and mention it now though. If you drop their blood sugar too fast, you can cause some cerebral problems, because that sudden, like we talked about, sudden drop in there, your brain will go into those coma-like states because I don't have adequate glucose. So as much as you want to be aggressive and get that 500 blood sugar down to 100 overnight, you're going to trickle them down. We'll learn about the number in 211, but I just want you to know that if you have a diabetic patient, they're going to be on an insulin drip, and they're going to be dropping their sugar slowly. And diet control. You're also going to watch the family. The family loves to bring in KFC and Checkers and all that good stuff because it's right there, and not very helpful in this state. But this is most common in diabetes type 1. Then hyperosmolar hyperglycemic syndrome, HHS, or you may see it in other resources that you have, hyperosmolar hyperglycemic non-ketotic, or non-ketotic, so no ketones syndrome, HHNS, same thing, same syndrome. And this is where your blood sugar is greater than 450, 500, doesn't matter. And then the only thing is we don't have acidosis, we don't have ketones, but I do have an elevated blood sugar, and I've had all of those problems that they're like the nausea, vomiting, abdominal pain, Kussmaul's, so some of the things. But I just don't have the ketosis or acidosis yet. So it's going to be treated the same: hydration, insulin pump, nutrition for diet control. Okay, easy peasy. Yes, Stephanie.
So is that like a preset you?
Not really, and this is most often in type 2 diabetes, because eventually they'll respond. But there's not a preset. Like, it's not common that you're going to have HHS and flop to DKA, or DKA and flop to. You will just present one or the other.
Okay.
So nurse management, we're going to worry about our lack of insulin, so we have to have constant insulin through some form or fashion, and we're going to need increased glucose, or so our body thinks, because of the brain, because we're not able to get it into my cell. So I'm going to desire or crave increased glucose levels because I can't use the sugar that's available. Your common orders that you may see, routine vital signs, your finger stick blood sugars, or serum glucoses in a needle stick, however they choose to do those. It could be caused from an inadequate amount of insulin, so we may have to adjust their insulin dosing, or start them all together. Maybe we just found out that they are diagnosed. Increased insulin requirements due to stress. So like we talked about, for most patients, when you're exercising, your body is supposed to elevate your blood sugar from your glycogen. But again, due to their lack of insulin, they can't use the glucose, so their glucose stores are going to go down, and stress will do that too. So like during prolonged periods of stress, so nursing school, Caroline, can I pick on you and not get mad? How much more insulin have you had to use since nursing school than before nursing school? I bet you rolling through them now.
Yeah.
So stress will wear and tear on it more. So just the way it works. Potassium levels, why?
Potassium and insulin work together, so one of them's high, one of them's low.
Also, what else? What condition are they gonna be? And so acidosis affects those potassium levels big time. So we will check potassium to monitor when they're in a acidotic state. Intake and output, because all those hydrating fluids that we're pushing in to dilute their sugar down, which should come back out in sugar pee. Watch them, it doesn't have it on here, but I would watch them for signs and symptoms of UTIs. And I would watch their kidney function, because sugar is hard on the kidneys. So all my sweet tea drinkers in the room. And then carbohydrate intake in meals. How many times have you seen in clinical already? Your diabetic patients are getting barbecue sandwiches with sweet potato on the side and a good old dinner roll and butter. You are the last stop. If you see that, remember, like, no thank you, let's get you some of those low glycemic index foods. Because they're not watching the kitchen like they should, in my opinion. But, moving on. When in doubt, check your blood sugar. So if your patient was cognizant, talking to you, answering questions appropriate, and you come back and don't wait till that 9 o'clock p.m. blood sugar to go check. Just spot check it right there and find out what's going on. We may have to give insulin as ordered. So one thing that you've probably seen already is at bedtime they love to cut their dose in half. I hate that that's just a blanket rule. I wish that that was saved more for the people who had the Somogi effect versus just everybody. But anyway, administer it as you need to. Isotonic fluids are the best because, again, going back to fluid and electrolytes, they're not going to cause a whole lot of shifting, and it's not going to mess with the glucose and all that. It's just kind of adding some volume for hydration, and the body can take what it needs and get rid of the rest.
Why wouldn't you do the hypertonic if they're, never mind, it's, yes, don't worry about it, keep going, sorry.
Go ahead and share your thought, because I want to know where your brain is.
They're losing salt, potassium, so I was gonna say, why not give hypertonic, but you wouldn't do that, so.
Not for the glucose. Nope. No glucose.
That's why I said, don't worry about you.
You're good. Yeah, you're good.
Yeah.
So you're gonna teach your patient to monitor for signs of hypo and hyperglycemia. So, and doing that report. And for those who've seen me in 112, I don't think I've done this for any groups in my 113. 112, I would always ask my patients, have you ever had a hypoglycemic reaction? What does that feel like for you? So that I'm aware of, if they call over the call light and they tell me that that's what, hypoglycemia, I need to go. Versus, you know, if it's not related, then I can kind of set my priority based on that. I'm gonna run to a hyperglycemia, I got a little bit of time. Reviewing your subcutaneous administration, teaching them about their medications, when to take them, when can you expect your blood sugar to go low, how to treat it if it does go low, regular blood glucose monitoring. So imagine that they don't have a chronic glucose monitor, or sorry, a continuous glucose monitor. They're having to do finger sticks, so actually having to plan their day for how inconvenient, but they need to carry it around in their bag, check it when they're doing mealtime. So every time something goes in your mouth, just good general rule, they need to be doing insulin for type 1. Every time food's in your mouth, do some insulin. And then healthy lifestyle, so you could recycle Mr. McCarty's 30 minutes of activity or the 90 of strenuous, all that kind of stuff that he talked about. So during the hospital, or when they have an acute process, we need even tighter glycemic control because we know that that helps with wound healing, thanks to our last PowerPoint and now what you know. And then we want to avoid complications with them because any damage that's done as far as vascular damage, that is irreversible. So that's how over years of having diabetes, mom has all the things, the PVD, the diabetic nephropathy, neuropathy, all the opathies that we're gonna see. So we want to avoid, and so that's why I go back to the teaching your type 1, your teenager diabetics so well, because they think because they have insulin, they've got instant coverage. It's still going to be wear and tear that's going to add up on you over time. That's irreversible vascular damage. And so if you'll kind of paint the picture to them, do you still want to have your 2 feet? Do you still want to have your legs to walk? Do you still want, it's kind of morbid to do to them, but you kind of have to grab their attention that way. Give them some buy-in. Okay, let's see how time-wise. Are y'all surviving? Or you need a minute?
Well, Sam has to go use the restroom.
You're good. Okay,
Ambulance food costs over.
sounds good. So 6:15, see you at 6:25. 6:25. Yes, probably went way up, because it's been 3 years and everybody sat at home and got huge, so, there's probably some more numbers there, but as of when this was written, 11.3%, so 1 in 10, if you wanna think about it that way. Look at the number, his number is 28.7 million, are affected, and that is 40% of your hospitalized patients. So we would agree with that. Most of the patients we've taken care of so far are diabetic, and I agree. It's more common in adults than juveniles, because juveniles are gonna be mostly your type 1s, but it can happen that they just don't produce enough insulin. So the problem for type 2 diabetes is that they either have insulin resistance, they're not producing enough, or they're not able to use it efficiently, or they could wind up being insulin dependent later. It shouldn't start out that way immediately, but they will wind up becoming dependent later if they do not manage their type 2. Speaking of type 2 diabetes, this is had 40 chocolates. That's great. All right. So your risk factors, because we love talking about the big 5. So your risk factors, body mass index of greater than, so it is very easy to have BMI greater than 26. According to BMI, I should drop dead because I am not severely but morbidly obese.
Me too.
According to mine, so.
Me too.
I feel bad, so, anyway. Physical inactivity, so a sedentary lifestyle, so all of us, so that's why I move so much, because I sit in that office all day, so when I come down here and move, I hope that doesn't distract y'all or bother you, it's just because I've been sitting and I wanna move. HDLs, your high density lipids, are less than 35, so HDL is a good or bad lipid? That's your good lipid, good lipid. LDL, you don't want lows, no lows. And then your triglycerides greater than 250. True story, telling old Mr. Fuller, metabolic syndrome, that's me. When I checked my triglycerides for the first time, because I turned 25, guess what mine were? Throw me a random number.
400.
More. How much? More.
I was at 525.
More.
8.
More.
9.
More.
I know you lying.
1103.
What's
So-
it now?
Now, at that point, I'm less than 200, like
Okay, good.
I'm fine. But the reason they were so high, remember, what was one of those components that puts you at risk for diabetes? It's not on here, but it was in type 1,
Stress.
genetic, family history. My dad is a heart history patient, and he just, all kinds of triglycerides. My cholesterols were fine, but my triglycerides were stupid. So I have the next line, what they call metabolic syndrome, which is where I am not insulin sensitive. So when my body produces insulin, it's like, cool, it's here, we're not gonna use it. And so I have insulin and glucose just floating around, which causes chronic inflammation and makes everybody puffy and bloaty and carry it all weird. Because if you look at my arm, I'd like to think that my arms and legs are not huge. It is all truncal. It is in the middle, and so that is due to the metabolic syndrome. Which predisposes you then for pre-diabetes, which is up next, where then your pancreas starts producing, it's like, well, if I'm making all this insulin and you're not gonna use it, I'm just not gonna make it anymore. And then we head for type 2. So metabolic syndrome, looking right here, looks like Mr. Fuller, if you wanna remember it that way. Abdominal obesity, hyperglycemia, hypertension, high triglycerides, and a lower HDL. And why it repeated twice is beyond me. But low HDL. Our concern here is that they are going to become pre-diabetic or type 2 diabetic. So things that can happen here are in the same risk of the type 2 diabetes. Due to the hyperglycemia, you still get the endothelial scarring. Hypertension, you still get all of the apathies, or can get all of the apathies. The high triglycerides puts you at increased risk of cardiac disease. And then same thing with the HDL, because the HDLs protect your heart. So since I don't have that cardiac protection. So what happens here is the cell membrane does not transport glucose across the cell despite the insulin that's there. So my body's like, well, if that's not enough insulin for you, I'm gonna make some more. And then because of the overworking beta cells of the pancreas, my pancreas starts to slowly shut down and fail or become less productive. So, let me ask you a question. Is metabolic syndrome curable or fixable?
No.
It is. Is type 2 diabetes curable or fixable? It is. So hopefully through diet change, exercise, medication, we can relieve that stressed out pancreas and get it back to working again, is our hope. So all of these, from this forward, the rest of the presentation, we can reverse it or at least decrease the side effects, slow the process down because of diet, exercise, medication. So it's going to look very much the same. Where have you seen that before? The 3 Ps, same before. But their biggest complaint is that they have poor wound healing. And so typically what will happen is, they're in Alabama anyway, we're barefoot outside playing with the kids. I step on a rock, cut my foot. And hey, used to, it'd be that this would heal up in a day or two. It's like week 3, week 4, this is still going on. Or that they're a machinist or something and got a laceration at work. Normally this heals up pretty quick and it's lingering around. So when they do test to see if it's infected, they're like, their blood sugar's like 200 to 300. And off we go. So some of the same tests we'll do is the A1C, just like before. The only new one this time is your random blood glucose. So they will literally have a little book that has random numbers. So it'll be like, check your blood sugar at 2 a.m., check your blood sugar at 7 a.m., check your blood sugar at 5:30 p.m., check your blood, and it's a different time every day because they're wanting a spot check to see, are you chronically high or is it associated with certain times of the day, things like that. So they're trying to see, is it a pattern or is it just based on your habits? So treatment's going to be all of the same things as before, so I won't beat a dead horse there. But the biggest thing about diabetes is teaching, and I can't preach to you enough, is about nutrition, and then that's the biggest component. It's mostly nutrition driven in this part of the world because of the food supply we talked about at the very beginning. If they are not into an exercise program, that doesn't mean that they need to go and have a Planet Fitness subscription and go 5 times a day and try to lift 5. Like, ease into it, because we know that habits are more effective than trying to cold turkey something. So actually give them an obtainable goal that they can do. So start out, just walk 10 minutes a day. Do 5,000 steps, get you a pedometer, do 5,000 steps. Then once they're doing that every day for a while and they're successful, bump that number up. If that makes sense for habits, it's much easier to win people over that way.
Takes 30 days to make a habit.
How many? 30?
That's right.
Usually 30, and it'll lock in. All right, so the best for last, if y'all can drive through this section, in your activities for in-class, you're going to see that there is a clinical judgment model activity, because what is the nursing process before we get into drugs? What's that little acronym? ADPI. So what's the A? Assess. Plan, implement, evaluate. Well, due to the NGN, they have changed it. Now it's like recognize cues, analyze cues. And that's about as far as I can get because I can't remember it all. But we're going to, instead of doing the big 5 where we look at it through an ADPI lens, next week we're going to try to implement it with the NGN model of recognizing cues. So what would be some cues, recognizable cues, that a patient might have diabetes? Hyperglycemia, polyuria, polyuria, and then analyzing the cues. Well, what does that mean the problem is? Is it diet-based? Is it insulin-based? So we'll get into that next week because we need to talk about Children's Expo at the end. So if you're interested in a potential position, I will tell you how to go about on Friday how to get that job. But we'll circle back. Tell you about drug. That's why I'm clipping the activity, but we will do it next week. With liver and thyroid and diabetes all in one. So your drug snapshot, if you forget everything else on the following slides, there's kind of some little acronym. This is how my brain works. Sam has rubbed off. No, I used to be like Sam, but a lot of students didn't care for it, so I quit doing it. But for diabetes, it's really helpful to kind of have a little saying or acronym about what the drug does. And so they're all here, so if you wanna use this kind of as a review, what do the big one-eyes do? Remember, it's the big guns. You can kinda quiz each other based on this slide, but each following slide will be one of the big ones, or be one of the savings. So big one-eyes, AKA the big guns. This is your first line of therapy for type 2 diabetes. Notice that's bolded, so if you wanna circle that, that is still the standard. That's your gold standard. If somebody has type 2, this is our first treatment we'll start them on. Metformin, AKA glucophage, is the drug here. It is going to decrease the glucose production by the liver. So it's inhibiting the production of what, if you want to get fancy? What's that liver making or turning that excess sugar into? Glycogen. So it's going to decrease or inhibit the production of glycogen. Also, it's going to increase tissue response to insulin. And you can even pencil this in because new science says it actually helps with patients with oxygen saturation of cerebral tissue. So like your sleep apnea patients and your Alzheimer's patients are getting increased benefits from metformin because it increases oxygenation to the brain. PCOS, there's all kinds of, metformin's a wonder drug. But let's talk about your side effect. Your
You said
first,
sleep apnea, PCOS, and what was the last one?
Alzheimer's. Cognitive impairment, I mean, just Alzheimer's is the one I go, but your dementias, vascular dementias and all that, because if you're helping your brain perfuse oxygen, then it's not getting depraved and breaking down like what happens. But your number one side effect, right there up top, severe GI upset, typically for the first 14 days, but usually your body will adjust to it and be calm. But I've had several students tell me that it does not, once you take it, but GI upset is your hallmark there. If they can just kind of push through it, stay near the toilet near the next 2 weeks, we will be okay. Of course, you're gonna monitor for signs and symptoms of UTIs, because again, how is this drug working? It's making them excrete excessive glucose through their urine, and so it puts them at risk for UTIs. Plus, all that sugar's hard on the kidneys, so a footnote, you may wanna watch their renal values, just to make sure that metabolizing that extra sugar, or excreting that extra sugar does not harm our kidneys. Our insulin stimulators, or AKA the secretagogues, because they help your pancreas to secrete more. Secrete what? So glimepiride, AKA Amaryl is the trade name. It is going to help your pancreas produce or secrete more insulin. It's also going to increase the tissue response, so it's really good for your insulin sensitive people, your metabolic syndromes, just like the big one-eyes. So let's say they're on the metformin and they're having GI upset, I can't get them to take it, the patient doesn't want it. This is kind of the next step into, it'll still be an oral anti-hyperglycemic, but it should not have as much side effects. But the side effects here, in my opinion, are a little more undesirable than just hugging the toilet. We're gonna have hypoglycemia, and so we teach them to take it with meals to minimize that occurrence. This one's pretty aggressive when they take it. Somebody wants to peek at the onset time for me in the background, that's helpful, but if not, no worries. It sets on pretty quick, so if they don't have something on their tummy, it will make them hypoglycemic. Causes some weight gain. What do you think that's about? Because you're what? You're eating with it, plus think about I can actually start using that glucose now, and so some of it can cross over and get stored as glycogen. So they'll just watch low glycemic foods, they'll be okay. UTIs, because it's a PO med, and then there's lots and lots of interactions with other drugs. So that's my personal reason I don't like this one. I wish they could hang out with metformin. But if that's the only drug they're taking, it's a great drug. So, the secretagogues, or secrete what? They're gonna help the pancreas secrete a little bit more insulin. Worried about hypoglycemia, lots of side effects with those. Insulin sensitizers, this is your get in the zone, and I don't mean AutoZone, but get in the zone. Their drugs end in ozone. So pioglitazone is your most common one. What is the trade name for that one? It's the green one. I want to say it's the Trilepta, but don't hold me to that. It's one very popular on TV if you're into the TV. Which America, why are we the only ones showing for all these pharmaceutical commercials? Get with the times, but we do. Aptos, that's not the one I know, that's the one that's listed there. But Aptos, it's gonna lower your glucose, decreasing the liver glucose production, so decreasing that glycogen again. Decreases your intestinal absorption of glucose, so the food that you eat, you will not pick up as much. So if you wanna think about it as a carb blocker, you can look at it that way, and then it helps insulin to actually do its job with what's available. So look at these lovely side effects. Increases of heart failure, so they're gonna have weight gain too, but more than 2 pounds in a day. Vision changes, weight gain, peripheral edema. It's gonna swell up and puff up. Who wants that? So again, just giving you options because patients have funny reasons and different ones you may see, but the most common you're gonna see is metformin and Amaryl, which is the glimepiride. You'll see those two. Then you have some insulin mimetics. If I were a mimetic or mimicking you, what am I doing? It's a copycat. So this is a copycat insulin that's using a natural gut hormone. Semaglutide, where have you heard that? Ozempic. It's an insulin mimicker. So what happens here is it's actually slowing down your GI tract, delaying your gastric emptying, so therefore you feel fuller or more satiated longer. It will give you some GI symptoms like reflux, maybe some chest fullness from the reflux, pancreatitis, because you're helping your pancreas to, like you're mimicking the pancreas, and the pancreas is like, hey, I'm the one in charge here, not you, so it will cause pancreatitis. And then renal insufficiency, because if you're fuller longer, you're not eating and drinking as much, so that makes your kidneys work a little harder to use that less volume. But most important thing with these is that GI stuff, because it's slowing it down. So not listed here, but if we kept going chasing the GI part, what's after that, you think? If I'm slowing or delaying gastric emptying, what?
Weight loss.
Well, good weight loss, but what?
Constipation.
Constipation, even worse than constipation. Small bowel obstruction or bowel obstruction. What was yours? Gastroparesis, which can already happen with diabetes. It can onset that. Lots and lots of GI stuff here. But it is a great drug. It does work with a lot of things. But there's a lot of research out now coming with your what they call GLP-1 inhibitors or these insulin mimetic depression, because your body doesn't have the adequate things, so it feels depraved, and so it goes into this like depressive state. So watch those patients for moods. Your DPP-4s is kind of like your GLP family as well. So don't stop the gliptin, so they'll typically end in a gliptin instead of your zones. Gliptins.
Saxagliptin? Saxagliptin? S-A-X-A?
I'm not familiar with that one.
Or it's
Sitagliptin.
Sita, yep. There's one. I just thought you were giving me some more that are out there.
Saxagliptin, I think it says, I can't pronounce, I'm gonna spell it to you. Onglyza.
Onglyza?
Yeah.
Something like that. Not a popular one. I've put it here because it's in your book. You can put this in your if you have time category. I don't anticipate a personal question, hint, hint on this one, but I do have to mention it because it's in the book and can be fair game for HESI, but not a very common drug. I mean, have you seen it in clinical yet?
No.
So we're gonna go with the drugs that you see in clinical, like insulins, metformin, Ozempic, because you will see those everywhere. So we'll stick with those because that's what I would hope you to see. Your insulins, we do have to go through all of those because I've seen all of these, so we have to go through all the insulins. Your rapids are going to be your logs or your pros. So think about your logs burn fast, your wood burns fast, those logs burn fast on the fire, or it works like a pro. So Humalog, Novolog, which translates into List Pro, and then surprisingly, because Norvo, Nordisk, it has to be the oddball, their Aspart. So, there's a different one. But those will be fast. So what's your onset? 15 to 30, so really quick. And then what's your peak?
1 to 2 hours.
And then, out of your system. So if I was gonna have a crash, when are they gonna crash? At the peak, 1 to 2 hours. So, the most important time for you to know, because this is gonna give you a whole bunch of times, would be your onset, because that's when you need to have either food in their face or the food needs to line up with the onset time. And then your peak is important because that's when you're most likely to have a hypoglycemic crash. So those would be your best ones. Your short, your Lens work for a few more mens. So Novolin or just your plain old regular insulin. So your short acting is that. So onset, just double for a nice easy number. The book's a little different, but we're gonna keep it simple. So for your short time, double, so 1 to 2 hours. Your peak, 2 to 4. So my crash would be 2 to 4. Intermediate, we're gonna set on 2 to 4. Peak 4 to 6. Crash 4 to 6. You see the game and just keep that going. Then long acting, those are gonna be 24 hours. When you, Ideally no, but they may create a peak during the nighttime, a nocturnal drop. So that's why I was like, don't just go with, oh, look at my little sweet patient in there. Because if they're confused or sweaty, I'd go check on them.
But it says there's no peak for that.
Scientifically, no, but I'm just talking, but your onset for it starts about the time that your body goes into the hypoglycemia or dropping it at night through your sleep. Even though there's not an actual peak of the drug due to natural process and the onset of the long acting, it can create a peak. So 2 to 4 a.m., actually touch your patient, or at least go get a close look. But your long actings have the funny names, so Glargin, Detamir, Degludec, weird names. If it's a weird name, it's probably a long acting. And then you've only got one type of mixed due to patent, and that's gonna be your Novolin, but they're gonna be your fractions. So for your mixed insulins, they'll be fractionated, and it'll tell you how much of intermediate and how much of regular. So they've got 70% of the vial will be your intermediate, your 30% of fast. Okay? And then notice it says onset times and peaks, and that's in your Saunders table 47.2. And that's what's going to help you the most predicting of when do I need to have food on the table and when am I expecting them to go down, because that's our 2 danger points for your diabetics in acute care. Questions on drugs? I know it's a lot, so other than just flashcarding them, that's the one time, I'm not a flashcard fan, but drugs is about the only time flashcard's really good. But I'm gonna quiz you off in just a second, no worries. So our complications for type 2, like we talked about previously, their most common problem is gonna be that HHS or HHNS, depending on what resource you're using. So that's where their blood sugar is gonna be elevated. What do they not have? And that's why I know it's the HHS.
Ketones and
No ketones, no acidosis. It's going to depress their immune system because of, remember that glucose is available, so bacteria can proliferate. So no, it doesn't take down their white blood cell count, but it eats up their white blood cell count that way from having to fight off potential invaders. So look at it that way. So some signs that they may be at risk for this condition is the infections or poor wound healing. And then our vascular effects, we're going to get microvascular and macrovascular. And I think I have slides for those. I do. So macrovascular is going to be your big blood cells. So coronary artery disease, coronary vascular disease, cardiomyopathy, hypertension, all those big passageways in your body. So all of the things that Mr. McCarty talked about for PAD, PVD, all that, That's gonna kind of roll into diabetes as well, because they're at risk for those cardiac conditions due to diabetes acting on those microvascular complications. The other thing that can also strangely happen is your erectile dysfunction, which he talked about with hypertension. And so that is one of the things that you'll be dealing with, so maybe some sexual health coaching and those medications. So all the same teachings that you did for low blood pressure, taking nitrates, all the things you would do again here. Microvascular is gonna be those teeny tiny vessels. And so retinopathy, where are those?
Yes.
Eyes, so they will actually, all right, so what do you think goes first? Obviously the retina, and then there's another type of eye. What's the other part of your eye that we call it? So you can have retinopathy or you can have macular degeneration. Have y'all heard of that?
Mhm.
So retina affects what part of their vision? So would the retina affect here or here?
It does a peripheral.
It's actually their central vision. Macular degeneration is gonna be your peripheral. Those kind of, hang on, Anna, you're absolutely correct.
Okay.
Don't listen to me, yes,
All right.
macular is your central, yep, get rid of your peripheral, so you start getting the snow cones, you're correct. So one more time, retinopathy is gonna affect your peripheral vision, and you're gonna get the blindfolds on. Nephropathy, that's your kidneys, and so this is where they'll start developing renal failure, kidney disease, acute kidney injury, all of those. And lastly, neuropathy, so that's your pins, needles, tingles, can't feel their toes. So testing, obviously for retinopathy, which we can rewind. Let's go back and talk about testing there. Obviously, what are you gonna do to test for coronary if they wind up having one of these conditions? What are some things that you know we do for patients that are at risk for coronary artery disease or heart stuff? What do they take every day? Could, but just more readily available, you can get it at Walgreens, 81 or 325, yep. You'll put them on some daily aspirin if they're diabetic, because you're worried about that. And if it's blood pressure related, you would put them on something like lisinopril. We love ACE inhibitors, y'all remember that from RAS, maybe? I don't know, fluid electrolytes feels like so long ago to y'all, I'm sure. So for hypertension, we like lisinopril for diabetics because it is kidney protective at first, but once they get into kidney disease, we want to take them off. It's weird. I don't know how it protects your kidney, but once your kidney's damaged, then it hurts it worse. Makes no sense, but that's what it does. And then obviously, what would be a drug that we could give them for PVD, or what could we do for PVD? What they're gonna start wearing, what they're gonna start doing. Yeah, they're gonna start doing those compression hose, elevate your feet when you're not active. You're gonna inspect your feet, you're gonna wear good proper fitting shoes, all things for PVD. Because diabetes, they're at risk for stuff, and now PVD, the vascular. Erectile dysfunction, pick out your favorite nitrate, and you're good to go. As far as retinopathy, some testing, just yearly vision exams. And once they are diagnosed with retinopathy, they need to see a retina specialist to preserve the vision the best they can. Nephropathy, what you would do there is that obviously a BUN and creatinine. And there's another test that I'm not going to expect you to know, but it's a fractionated test where they look at their BUN to their albumin. It's looking for microalbuminuria, where there is small amounts of albumin being excreted by the kidneys. That is one of the earliest signs of kidney damage. And if that happens, then you are going to want to set them up with a nephrologist to manage that condition. So hopefully we fight off dialysis. Neuropathy, the test for that's going to be called a filament test or a tensile test. They'll take a little fiber optic piece of cable, it's on a little piece of tape, and I poke to parts of your body, like we blindfold you and I poke you with that little filament. Where did you feel me touch you? On usually their lower extremities, typically below the knee. They will not feel the filament, and that will tell me neuropathy. And they'll also have the complaints of pins and needles on their extremities. We're going to revisit all of those from type 1. We repeat again, so I'm not going to beat a dead horse. Some common orders for type 2 diabetes, very much the same thing as before. There's my test, the urine for the microalbumin, that. That's your fractionated test. They look at your BUN over the albumin, and that gives you this number, and that just, for easy, that if that's detected in your urine, then you're at risk. And then worried about your carbohydrate intake at meals. I think y'all know how to take care of a diabetic. The interesting thing here down at the bottom, why are we worried about administering antibiotics to this group?
You said they should have higher risk for infection.
So in the hospital, surprisingly, I think it's crazy, but it is what we're doing. They may prophylactically administer a patient antibiotics that is diabetic because of something that could be introduced to them. Because think about it, we're doing venipuncture and all that on them, so that's introducing bacteria to them. If we do any lines or anything with them, that's just everything that they're introduced to in the hospital puts them at risk. So they may get prophylactic antibiotics even though they don't have an active infection or an elevated WBC. May see that. Typical things we're going to do for them, teach them signs and symptoms. Foot care is huge, but nothing on this slide I think that surprises anybody. They're repeats from previous. Tight glycemic control. So here's your all-in-one kind of study sheet. Not everything, but kind of the big points. I love to give you big points. So type 1 versus type 2. So rather than giving you the summary slide, I'm gonna go pull prep work and get you there. So, let's see. What type of diabetes would have an age of onset per textbook less than 30, but typically around the age of 10?
Type 1.
I like it. Whose signs and symptoms would be the presence of ketones? I like it. This type of diabetes is caused later in life as the pancreas is no longer responsive to insulin or does not produce sufficient insulin. There we go. This type of diabetes typically experiences hypoglycemia during exercise.
2.
1. They're the most critical because remember they have no insulin, so they can't use the glucose they have. This type of diabetes is not insulin dependent and may take oral meds.
2.
What are some signs and symptoms that your patient might be hypoglycemic? Fatigue, brain fog, what else? Comatose like state, like that. Kussmaul's respiration, no, just kidding, that goes with who? I love it. What are signs and symptoms? Sugar is high. We didn't talk about it, but hot and dry is the poem for hyperglycemia, hot and dry. And then increased thirst, because your body's going to try to make you pee out the sugar. Yep. What else? You can have me some. Who typically experiences DKA? Who experiences HHS? Type 2. Now, that's not to say that one can't have the other, but classically, like your majority patient. What are some microvascular problems that occur?
Retinopathy.
So give me all the opathies. For micro, just make it opathies.
Nephropathy and neuropathy.
So eyes, kidneys, and neuros in your legs.
R and N.
R and
You're gonna be an RN soon enough. I know.
Maybe.
Signs and or what are some macrovascular? Who's the most common there?
Type
I'm gonna go PAD and PVD. Those are very common because how many diabetics you know losing feet? So I'd start there. And then yes, cardiomyopathy, cardiovascular disease, coronary artery disease, all the things. What's the 15-15 rule?
For every 15 grams.
There's 2 of them. So for insulin purposes, for every 15, how many?
1 unit.
A unit. And then if they actively have hypoglycemia,
You're checking them every 15 minutes.
15 grams, 15 minutes later, recheck until you get it above 70. What if your patient is not following commands, confused, lethargic, what's kind of the best intervention to get that sugar up? Who? I like D50 is a good one. What else? No, they're confused, not with it. I don't stick anything in their mouth. Well, that's the D50. What's that other one?
Calcium glucan.
The inject.
Glucagon.
Glucagon.
Under the tongue.
Yep. And then if they're coherent, can follow commands, can swallow all that, then we can do any of those PO options. Let's see. Recommended diet for diabetes, and don't just tell me diabetic diet. What was that?
Low carb, high protein.
LGI is what we're gonna say. What's the LGI?
Low glycemic.
Low glycemic index. And the one that follows, does anybody have a fad diet that follows those really well? Atkins, Mediterranean, and what's the new name for Atkins? Keto.
Keto.
Is another one, so any of those they may follow. But the danger for ketos and type 1s is no, because why? Because they're gonna produce the ketones and it's gonna send them over. So that's the trick. That's the trick. Now for type 2, you might get away for a ketone diet if you have some insulin production, but if you are insulin dependent, no keto for you. You just have to have low glycemic food. So Mediterranean is probably one of the better out there for them. I say diabetic, you say, name my part. I love it. What is the best teaching method that demonstrates patient understanding?
Teach back.
Teach back or return demonstration, either verb is fine. What is Charcot foot?
Nerve damage due to neuropathy.
Neuropathy, so has anybody ever seen a Charcot foot?
The big toe kind of turned in.
Oh, it's the whole foot. This foot
Yeah.
is messed up. Let me tell you.
Charcuterie foot.
I wish. Be a delicious foot. But what happens is it's kind of a reverse club foot if you think about it. So their foot has lost all of the nerve conduction there, so it can no longer hold the arch. Because think about your arch actually has an impulse to hold there. So as those muscles get weak from lack of sensation, they start to flatten out, and then they can actually hyper flat, if you will, and that's what gives it that dip in the middle, a fallen arch. And so Charcot foot. So think about if they can't feel their foot, think about what this also does for how they ambulate. So you can get all kind of musculoskeletal accommodation problems from trying to figure out how to walk on that. And then it also puts them more prone to damage that foot. If they will wear proper fitting shoes and wear an arch support shoe, we can help preserve them from having Charcot foot and having all those issues with ambulation. So foot all the time for diabetes. Biotech is one company that comes to mind. They are in Birmingham, Alabama, that does the custom fit orthotics for these severely diabetic impaired people. And they can help preserve that arch and keep their arch up. We'll also talk about sometimes TENS units and other types things that they can wear to try to help with. They'll also do nerve conduction testing and nerve conduction interventions to try to preserve. Very advanced, don't have to know, but just good to talk about. Give me a hallmark drug for each of these. Who's your secretagogue? Secreta what? Who? Glimepiride or Emeril. Big Benides, big guns. Metformin, get in the zone. Get in the ozone. Get in the Ozempic zone with that one. There you go. That's your pioglitazone. And coming up next, your insulin mimetics or the GLP-1s, that's your Ozempic, which is the semaglutide. And then we're not even gonna worry about the DDP-4. Long-acting insulin, give me one of those. Who? Flargan or Detamir for your Lemire. When's your onset? Onset for long-acting. For long?
One,
I think it's 1 to 2.
1.5 hours. 1 and 1.5.
Okay. And then when's the peak?
There's no
Does not have one. And how long does it last me?
24
Love it. Which one's gonna hit me in 15 to 30 minutes? When they gonna crash?
2 hours.
1 to 2 hours. All right, what about, what type of insulin is gonna be my 70-30, 80-20?
Or Novolin.
Novolin.
But that, well, it is this type of, but what type of insulin?
Oh,
The fraction.
It's a mix, so what are my two mixed components?
Regular and.
Regular and intermediate. Then your let's say we did rapid, give me a short acting,
regular insulin.
Novolin or regular insulin, I love it. So 1 to 2 hours, crashing 2 to 4. What are your most common times of the day to do your blood sugar checks? Minimum of,
Before meals.
I like those, so we're gonna call them pre-prandial. So before meals is your fancy term, pre-prandial. And then, so at least 3 times plus 1 more, right? You want that bedtime snack. So usually most patients check their blood sugar 4 times a day. If they're on tube feeding, you also check their blood sugar 4 times a day, but instead of with mealtime, since it's continuous tube feed, you're just gonna do it when?
The same. It's like
Good.
every 8 hours.
Every 6. So every 6 hours. So they're typically at 6 and 12, or is what you'll commonly see. But for tube feed, you still maintain the 4 times a day, but since it's a continuous feed instead of spiked meals. Now, I'm gonna be devil's advocate. What if you're bolus feeding your tube feed patient?
Then you should.
You're gonna do the standard ACHS, which is the 7, or the 7-12, whatever their times are, but with meals and at bedtime. What is our lab that's gonna diagnose us with diabetes?
A1C.
Hemoglobin A1C. How often can you check an A1C or expect it to change?
We didn't go.
Every
for
3
that.
I know. I like it 3 to 6 months, depending on your insurance company. 3 months, I could check it every 3 months if my insurance would allow, but most insurances only allow for twice a year. It just depends on insurance, but 3 to 6 months, we would have it to change. But like if I checked it today and I check it next week, it's not gonna have enough time to change. Ideal blood glucose range according to the ADA. We did that. What is a fasting glucose test?
Don't eat.
You do read.
Don't eat, so they were NPO at midnight, and then I'm gonna check it about 7 or 8 in the morning, see where they are. In theory, they should be normal, but if it's not, it's elevated, they could have one of 2 syndromes, which is what? Down or Samoghi.
Yes. Is it 8 hours for fasting, a minimum?
Typically 8. What is your postprandial glucose test?
That is directly after they eat and then 2 hours later.
They feed you a set amount of carbs so they know what your blood sugar should do, and if it doesn't respond that way, that you are likely insulin sensitive or insulin resistant. Insulin resistant or insulin dependent. Some causes of the upsurge in diabetes. Obesity pandemic, food, chronic illnesses, and food supply, I like all of those. Who are your most common races for diabetes?
African and Asian.
For diabetes, what? Not for the diabetes?
Oh.
Now, I like the second answer y'all gave me.
Asian,
Caucasian and Asian.
Caucasian and.
Caucasian and Asian. And now an uptick of Latin American and of Native American have also had an uptick, so we can add those to the list. But classically, Caucasian, Asian are gonna have those. And why would Asians have diabetes?
Right.
Because now, again, going back to food supply, but if they're no longer washing the rice, and like following ancient tradition of washing the rice, keeping the fiber cap, all that kind of thing, is how we get into that. But Native American, Latin American, also picking up, hence all of the Coca-Cola, because in Mexico, they use the real stuff. So they got the good Coke down there, which, anyway, never mind, those stories.
Get it.
Hmm?
That's the reason why we get it from there.
Right, it's good stuff. But they will not give you that glass bottle down there, y'all. They will pour it in a Ziploc bag, cause you know, they get reimbursed for the glass and aluminum. And so they will literally put it in a Ziploc bag with straw and that, I thought that was the weirdest thing when I didn't know that until I traveled there. And it was pretty weird. So you're gonna find me some foods that are low glycemic index. What are some causes or risk factors for type 1 diabetes?
Genetics.
Genetics is the greatest contributor.
Autoimmune disease.
Ooh. 3 P's of diabetes.
Polyuria, polydipsia, polyphagia.
Eat a lot, drink a lot, pee a lot. And so, and then to know a little bit about why the cycle happens. So I have a sugar crash, I need sugar, my sugar goes up, so then my body can't do anything with it correctly, so then I drink to wash it down, and then I pee it all out, and that puts me at risk for UTIs, so watch them for that. You got your drugs. If you're a type 1 diabetic, there's 2 recommended or favorite insulin treatment options. One I carry with me and one side saddle. Pump and pin, I like both of those. Good stuff. Which one of the 2 is the rebound hyperglycemia in the wee morning hours?
That's Dawn.
Samogi, rebound Samogi. And then, which one is linked to the human growth hormone and causes hyperglycemia in the wee morning hours? That's your dawn. The dawn most happens with your kids. What's diabetics?
You rebound off.
I think we got the big nutshell picture there, having some treatment stuff. So let's talk Children's Expos. I'm gonna stop our recording while we're,